This is Andy Oram, recording for HIMSS TV, and I'm with Adrian Gropper, who I've been knowing for many years in the Boston area, raising cane there, and in Washington, D.C. with ONC and other organizations. And we're going to talk today about data exchange and about the way to get patients and physicians in charge of their own data. So perhaps we could start out by talking a bit about the DIRECT project and what it offers that wasn't there before.
The DIRECT project is huge for two reasons. It's a universal address space, like email, that includes everybody, institutions, individuals, patients, and doctors. It introduces no privacy problems because it's a point-to-point secure messaging system, encrypted and everything else. And as a result of Meaningful Use Stage 2, it integrates with the workflow of physicians in and out of all certified EHR technologies.
Yeah, so everybody's supposed to support it, and as I understand it, the vendors are saying they're going to support DIRECT.
They have to. It's the law.
And there's also the question of certificates, because if someone comes to you and says, I'm Andy Oram, you can't necessarily trust me, you need to get a certificate. And maybe you can explain how the certificate system will work in your approach.
My approach, which is also a patient privacy rights approach. HIPAA is at the core of this issue. The liability of the providers is based on HIPAA. And I should say the institutions as well as the physicians. What happens inside HIPAA is that there is no absolute requirement for biometric IDs or other trusted credentials in order to receive medical care. The person can receive medical care if they are well known, is the term of art, to the practice. So if you recognize me and you've always treated me, HIPAA therefore should extend and will extend to communications that are done using DIRECT over the internet. And the way that it can be done that way is to allow patients to self-sign their certificates and present those to the practice as a way of associating their well-known entity with the certificates that they're using to communicate.
So they could give a USB stick or something when they go into the office, perhaps?
They could email address that they verify. In other words, you send a test message like you do every day on the internet when you sign up for something. And I want to point out another very important thing about this. As a result of DIRECT and work that's going on in the Blue Button Plus initiative by ONC, the HIPAA people, the Office of Civil Rights, were asked to provide guidance as to whether patients had absolute control over the method of communication. So that if they went to a doctor or to a hospital and said, I want my records to be sent to me using regular email, without encryption, without all those things that covered entities and HIPAA talk about, can they do that? And again, HIPAA authorities came back and said very clearly, yes, the patient, once the patient asks you to do something clearly, and maybe you've told them about what the risks are if you want, you are under a safe harbor and you are no longer you no longer have a risk.
Now, we know that the meaningful use requirements also require the doctors to release the records, and there are various ways that vendors are allowing patients to get access to records. Blue Button makes it easy. So what process do you see patients going through, or would you like an empowered patient to go through?
Well, this is the nice thing, is that the process is being worked out as something that even President Clinton talked about just a few minutes ago, which is called Blue Button, or nowadays it's Blue Button Plus. And I like to think of Blue Button and this method that you're asking for as patient-directed exchange. The original Blue Button was great, but it required the effectively it required sneakernet. It required the patient to be part of any transaction in either direction in order for it to occur. Health information exchange, in order to be universal and uniformly applicable, needs to be able to happen even when the patient is asleep or when the patient frankly doesn't care, but has given explicit consent for it to happen. And so Blue Button is, and Blue Button Plus in particular, is the mechanisms. There's a push component and a pull or query component that enables for patient-directed exchange to be the dominant form of health information exchange going forward.
No, originally it was all pull, I understand, and now you're asking that...
Push. In other words, direct by itself is like email. You originate it and it goes to where you send it. And before direct even, there was this thing called PCAST, and PCAST basically said the future, the President's Commission on whatever it was, the future is to let information stay in place, whatever the data holder or the record holder was, it would stay there, and simply control the query and transfer of information according to the privacy practices that are enforced by the patient. And this is a highly scalable way to do it. It raises some issues, but fewer issues than the aggregation of information in large databases that have uncertain governance. However, if you have purely a push system and you don't have a central store of information, you don't really have a ready way to ask a question or to interrogate or have random access into a piece of a record. And these records get big, of course. So there needs to be a way to pull information or to query information, and this is now being built in Blue Button Plus on top of something that we all use hundreds of times a day sometimes, which is OAuth 2.0, the way we connect Twitter, Facebook, New York Times, etc. This mechanism is being used in that same way to capture the authorization of the patient for these things to be used on their behalf until that right is revoked again by the patient.
And it builds in segmentation, too.
No, segmentation actually is a separate layer. The nice thing, OAuth 2, you are right, allows for segmentation. It does not ask you to share a password. Just like you wouldn't share your Gmail password with Twitter, because at that point all sorts of bad things happen, and HIPAA wouldn't even allow that. So OAuth provides the ability to have a valet key effectively, to give limited access, and segmentation that is then built on top of this capability can make the system much more scalable and much more secure. But it's not really the same thing. Control of privacy and control of information flow can exist as a foundation regardless of whether you're streaming images or moving documents or in one direction or the other.
Well, this sounds great. We have standards that have been well tested. We have the government and the vendors lining up. So what dangers do we have to watch for at this point?
Well, the major danger is that the predominant business model of this industry is a vendor lock-in business model where 60% of the revenues are for interfaces rather than for actual services or gadgets or whatever. What this means is that on the one hand, introducing the liquidity that people talk about versus actually just paying lip service to the liquidity that people talk about is the difference between locking in between the dominant business model of this industry. It is something that doesn't happen on the internet almost at all, and it is a huge impediment to progress and health reform.
So before we wrap up, I think it's important to let people know that Patient Privacy Rights has a conference coming up in June in Washington, D.C., and I suppose this will be one of the topics.
The theme of the June conference is actually the value of your health data. And it's a very interesting story that's going to be approached on an international basis in terms of data privacy laws and things that involve advertising and other things in Europe. But the fundamental thing is that right now patients are not deriving most of the value of their data. That value might be captured by an institution, it might be captured by the insurer, it might be captured by somebody else, but patients that do not control their own data face risks in employment discrimination, in disability insurance discrimination, and in certain aspects of healthcare, even with universal coverage coming into play. And it would be, for instance, incredibly valuable if patients could use an accountant the way they use them to file taxes to get advice, personal advice, on which health insurance plan to buy from these health information exchanges that are starting to be part of the law as of 2014. So one of the core ideas of privacy is capturing the value of your own data for your own benefit rather than being sold as a component of somebody else's business.
So it's back to give me my damn data.
Absolutely.
Thank you, Adrian.